Hi, this is Let's Talk About It, an interactive webinar on painful sex in the female. I'm Dr. Robert Moldwin. I'm professor of urology and director of the Pelvic Pain Center at the Arthur Smith Institute for Urology for the North Shore-LIJ Health System. And with me today is Dr. Sonia Bahlani, who's a gynecologist and assistant professor, also at the Arthur Smith Institute for Urology within the Pelvic Pain Center. And also joining me today is Marina Ruzimovsky. Marina is a nurse practitioner who works within the Pelvic Pain Center. Marina has a lot of experience in the field of women's health, spanning about 15 years and about 9 or 10 years specifically dealing with pelvic pain and all the issues involved in that arena. Other members of our team who could not be here tonight are Monica Johnson, who's an RN, who's head of our clinical research program, Dr. Mila Frankel, who's head of physical therapy, and Dr. Barbara Shorter, who's professor of dietetics at Long Island University. And Barbara, in fact, won the Best Dietitian of the Year award for Long Island for this year, so we're really proud of her. In any case, this is an interactive webinar, and you're all invited to participate, asking questions throughout this session. We'll probably get to the question and answer period towards the end of today's discussion. We have a lot of topics to go through within the realm of sexual pain in the female. So the big question is, why are we doing this? This is our first webinar with reference to any topic in the field of pelvic pain. And we decided to do this mainly because pelvic pain in the female is often, people just don't talk about it. They even go to their clinicians and they don't bring up the topic, whether for fear of embarrassment, whether for just that they don't even know that their clinician might be able to treat some of these problems. And with that being said, they suffer in silence. They have a poor quality of life, and it certainly has a major impact, not only on the patient, but those they love as well. So hopefully we'll be getting to a bunch of these topics, and at the end of this, you'll realize that there are a lot of therapies that may be available to you or to those who you love. One thing that, some topics that we won't be covering tonight basically involve acute sources of pain. So, for example, urinary tract infections, vaginal yeast infections. Of course, all of these things can have an impact on sexual pain, but we're going to be really talking about conditions of chronic pain. And the specific clinical scenarios that we'll be talking about involve vulvodynia, that's vulvar pain. We'll be talking about interstitial cystitis or painful bladder syndrome. And something, the last topic we'll probably get to tonight will be pelvic floor dysfunction, which is basically muscle spasm of the pelvic floor, often the old term being vaginismus, that can be a real problem and can coexist with any of these other disorders. So to start things rolling, I'm going to pose the first question to Dr. Bahlani. Exactly how common is pelvic pain with relation to sexual pain in the female? And how do these patients usually present in practice?
So sexual pain is actually quite common. And it's thought to be found in about 30% of women, and at some point in their lives presenting this way. It's hard to really pinpoint a specific way that each patient presents because there's no standardization. You know, patients don't read a textbook. Everybody has different symptoms that actually kind of contribute to their sexual pain. Some patients will say, oh, I have a lot of pain during initial penetration, so when we first get started, or I have pain with deep penetration. But most of their symptoms usually pretty much vary, which is why it's important to really take a really good history and physical in order to figure out what's causing their pain.
So is that sort of the history and physical? We talk about how we approach these patients. Is that sort of one of the cornerstones?
Oh, absolutely. That's first and foremost. And while it sounds pretty simple, and you're probably like, history and physical, you know, there's no big imaging study we can do or anything like that. History and physical is really the crux of figuring out what's going on with these patients. And we tend to take a good amount of time with each of our patients. We spend a whole hour with them kind of figuring out what's going on because this is so important.
I'm sure these patients come with a lot of, we'll say baggage. Lots of other, I'm sure they've seen other clinicians before.
Absolutely.
And how do you sort through all that?
Well, I mean, sorting through everything that they've been through, I think the big thing that I've been taught is the whole concept of healing young and kind of figuring out where they've been and what therapies they've tried, what has worked, what hasn't worked, and that really helps.
So let's move on to the first topic. So that gives us sort of a general overview of how we sort of look at patients when they walk through the door. Let's start talking about some of these common causes of sexual pain. And we'll start off with interstitial cystitis, or what's been commonly called the bladder pain syndrome. So my next question comes to Marina. How in the world can a bladder be the source of sexual pain? And how do you, and if you think the bladder is the source, how do you diagnose the bladder as the source?
Well, interstitial cystitis or bladder pain syndrome in the current definition of pain with bladder feeling is one of the causes of, one of the cardinal signs of the condition. Patients often present with urinary urgency, frequency, burning, and many other symptoms. Symptomology leads to having pain with intercourse. Urethra in females is tends to be very sensitive, and that will also have an impact. Incidentally, interstitial cystitis is a diagnosis of exclusion, and only 15% of patients with interstitial cystitis have a visible sign, which is a famous Hanner's lesion that can be seen on cystoscopy. The rest of the population pretty much walks around with symptoms, and these patients travel from provider to the provider at times, not finding answers. When patients reach the Smith Institute, hopefully we're able to help them to rule out most common causes of urgency frequency, such as overactive bladder, urinary tract infections, and possibly other cancerous conditions, if such exist.
So basically you're saying that this is a bladder pain condition, but a lot of these patients also have some of the similarities to other conditions, for example, urinary tract infections, overactive bladders. So that's how they're coming to you right now, and they just haven't done well with these therapies?
Oh, absolutely. Patients are coming in with urinary urgency frequency, pain with intercourse, urethral discomfort, and multiple patients have been treated with long courses of antibiotics with actually absence of urinary tract infections. Once again, to stress the point of Dr. Bahlani, careful history and physical examination is very important for diagnosis of interstitial cystitis.
Do you ever have to do, aside from the history and physical examination that Dr. Bahlani was talking about, any other tests that you run to like make sure there's no infection or, God forbid, cancer or anything like that?
The routine urine analysis and culture will certainly help to rule out presence of urinary tract infections. If the patients come in with a history of microscopic hematuria, the cytology or cystoscopy might be helpful. But the large, expensive tests such as CAT scans and are probably not going to be necessary in this case.
Okay, so that's really helpful. There's another question I was going to ask you about sex again, because that's what the topic is tonight. So the bladder, I guess, is a painful organ, and therefore, how does it work into sex, though?
The bladder, yes, the bladder being in pain would certainly impact how the patient perceives intercourse that might be coming, in the sense that the patients would certainly be trying to shy away from having an intercourse. Painful urethra will cause the woman to be more alert and hence guarding, which will cause more discomfort.
So the bladder being a sensitive organ, so if any pressure, for example, would be applied from on top or from within the vaginal vault, or even, like you say, the urethra, that might be the source of pain.
Absolutely.
Okay. And then you say again, once you get pain, then you fear more pain, and then you have further problems.
Yes.
I see. Okay. let me pose the next question to Dr. Bahlani. So now we have this patient with interstitial cystitis. Is there a pill you got for them?
I get this
Cureless.
question by all my patients, and I always tell them, I wish I had a magic pill for you. I wish there was one single thing I could do to cure your pain. And the answer is no. But there are multiple things we can do. It's multifactorial, right? So, I mean, if you want to start off with the most conservative things that we can do, which are actually shown to be pretty helpful, some patients will tell me, you know, I had tomatoes, I had a slice of pizza, and my symptoms got really bad. So, you know, understanding, recognizing dietary triggers is a huge, important thing that is pretty conservative, but can help patients feel better. Obviously, some patients are not diet sensitive, and some patients have their symptoms and they have it whether they eat something or they don't eat something. And for those patients, we can use medical therapy. There's medications they can take orally that we can give them to help them. There's also therapies that we actually put into the bladder to try and help interstitial cystitis, which have definitely shown to be helpful, and they're not as invasive as they may sound. And then, you know, you just graduate up from that. Again, surgery, there's certain specific procedures you can do with patients who have, like Marina said, Hunner's lesions. You can
Use
burn
those
them.
areas of inflammation.
Areas of inflammation. You can burn them. You can inject them. So, I mean, therapy just varies based on exactly what's the cause.
So no patient there's no sort of standard approach for every single patient.
No.
Everybody's a little
And that's
different.
the theme of tonight, I think. There's no standard approach. There's no standard way these patients present or anything like that.
Okay. So let's move on to vulvodynia. As I mentioned earlier on, this vulvar pain. How could that not be associated with discomfort or frank pain during sexual relations? Tell us, how do you define what is vulvodynia? I mean, it sounds like it's sort of a yeast infection gone ballistic. What is it?
Not actually necessary. I think vulvodynia is more of the condition where yeast infection has been ruled out, including other sources of possible dermatologic conditions of the vulva or sexually transmitted diseases, as well as the yeast.
So it's sort of like interstitial cystitis in a way, right?
Vulvodynia is another diagnosis of exclusion, and vulvodynia comes actually in two different flavors, where in one flavor the patient just constantly complaining of this uncomfortable sensation down in the vulvar region, whether it's labia, external labia, labia majora, labia minora, or vestibule, and this pressure can occur simply from prolonged sitting, wearing tight clothing, or even perhaps using a different detergent, as some patients would say. In other cases, the vulvodynia is provoked, where a young woman for the first time tries to wear a tampon, or even the first penetration that would cause severe pain and pressure in the area.
So one would imagine that even beyond the realm of sexuality, this must be a horrible, condition to live with. I mean, it sounds to me like you can't wear, it even affects the type of clothing you wear.
Correct.
And that's,
the patients, yes, lots of patients with generalized vulvodynia would tend to wear loose-fitting clothing. And going back to the sexual problems, this would be probably one of the biggest conditions that is involved in painful sex, and maybe having difficulties with your partners, as well as significant difficulties from the social standpoint. I am sure that patients get very depressed and frustrated as they trying to find a solution for the treatment of the problem.
so how do you, as approaching patients from a therapeutic perspective, it sounds like there are different kinds of vulvodynia scenarios. One where it's direct, patients are always feeling burning. Others where it's very tender to the touch and so forth. So I would imagine that might extrapolate into different types of therapies available. Could you discuss that a bit?
I mean, and there's actually a third vulvodynia
Okay.
or vestibulodynia, which is mixed, which is where patients can have this generalized sensation of burning, and then also when they're provoked or when something's inserted
Right.
near or at the vestibule, they'll feel more pain. And so therapy is really directed at symptomatology or at how these patients are feeling. And so for patients that have constant burning, we usually give them oral therapy because they're burning all the time, and so they need something in their system all the time to help this symptom. And I shouldn't just say burning, because it's burning, it's pain, it's however you want to describe it. That's why we now call it vestibulodynia. And for patients with more of a provoked vestibulodynia, where actually the test that we do is called a Q-tip test, because we actually try and not to cause pain, but to provoke those areas to see where it's coming from. There have been many new compounded therapies that have been shown to be really effective in these patients, which is great.
You say compound. What do you mean by that?
That's a good question, because I use it all the time and I don't even think about it. Compounded medications are medicated. The reason that we call them compounded is because they're mixed up by a compounding pharmacy, and they're usually topical. So you don't have to take them by mouth. You can take them and just place them on the area that's actually experiencing pain.
So speaking about topical agents, I know you're heading a new project here of a new medication to deal with vulvodynia. You want to just discuss that for a moment?
Yeah, well, actually, it's excellent because the National Vulvodynia Association has given us a grant to actually look at the topical use of DMSO, and you may have heard of this term called DMSO, dimethyl sulfoxide, in the treatment of interstitial cystitis. And so we thought, well, if this is working in patients with interstitial cystitis, it has anti-inflammatory and it helps pain, why wouldn't it work in patients with vulvodynia, seeing as the two kind of conditions correlate, like icy for the vagina almost. So we'll be actually using this medication topically for patients with vulvodynia, and it's been FDA approved at this point, so it's great.
Yeah, we're very excited about the results. So those trials will begin.
They've begun.
They've begun. So there we go. We're going to move on to our last topic tonight, and then we already have some questions from the viewers out there. We're going to talk about pelvic floor dysfunction. Now, I'm going to just mention a few words about pelvic floor dysfunction, because we all collectively, we do a huge amount of work in this particular field. It is a very common source of sexual pain. And probably the best way to describe pelvic floor dysfunction is that it's sort of a cramp of the muscles of the pelvic floor, the muscles that hold all the pelvic organs in place, the vaginal valve, the rectum, the bladder, etc. And these muscles also function in terms of how they work, in terms of how they interact with those pelvic structures. So, for example, the muscles during sexual intercourse, they need to relax, contract, and so forth. Certainly during an orgasm, there's intense contraction of those muscles. And you can imagine if you have a cramp or a spasm in that musculature, you're going to have a big problem. The muscles are also responsible for how we have bowel movements, for how we urinate, the fact that we can get urine out in a good stream and so forth. And so what we often find in patients is that they have all sorts of, when those muscles go, the function of those muscles goes awry, patients come in with complaints feeling like they're sitting on a golf ball. They're complaining of poor flow of their urine. They're complaining of constipation. And interestingly, they also complain of sexual pain, either pain at the time of orgasm. Pain could be 24 hours after orgasm. Even if the patient doesn't have orgasm, they still have pain during, after, or what have you during sexual relations. So these are all it's a very important topic. And probably the most important thing to keep in mind is that pelvic floor dysfunction often coexists with interstitial cystitis, with vulvodynia. And I should also mention, of course, that all of these problems, we have many patients who have all three conditions as a source of sexual pain and even pain outside the realm of sexual relations. So that being said, I was just wondering if, Marina, we have sort of a general approach to the patient who has these muscle spasms, and maybe perhaps some words about some conservative therapy that patients can even institute at home without even seeing a doctor or a nurse practitioner.
So the conservative therapies usually come first, and if I can just mention one thing, essentially, physical therapy has become very important, integral part of treatment of both conditions, vulvodynia, I'm very sorry, interstitial cystitis and pelvic floor muscle spasm, and physical therapy is actually on guidelines for treatment of these conditions. But taking it back a little bit, as Dr. Moldwin mentioned, treatment of constipation is crucial for helping the patient with tight pelvic floor and painful bladder. Using heat to the pelvic area as much as possible promotes relaxation of the pelvic musculature, and of course, simple things like considering not pushing with urination, which will essentially help both interstitial cystitis and pelvic floor dysfunction. It will be also very important to have a good physical therapist in practice, or have a referral to a good physical therapist once again to consider for patients to work with physical therapists.
So those are some very simple things, aside from physical therapy that they don't have access to at home, but some simple things. And of course, we also use a lot of muscle relaxants. And I think probably one of the biggest problems we have with muscle dysfunction is just the fact that there are lots of vicious cycles that go on. If a patient, for example, has pain, that initial pain, whatever the cause of pain is, there's that fear factor that comes into play. So what happens is there's a tendency to guard. So the next time they enter into sexual relations, they're already tight. The muscles are tight, spasm, and then any interaction, whether it be penovaginal intercourse, the use of toys, etc., what have you, any pressure applied to those muscles creates even more pain, more fear, more stress, and even tighter muscles. So it becomes a vicious cycle. And our job is basically to get people out of that cycle. We're talking about really conservative therapies for pelvic floor dysfunction at this point. We all are involved in more aggressive therapies. Perhaps Dr. Bahlani could comment on some of those.
Yeah, I mean, I always think of pelvic floor dysfunction. I always tell my patients, it's like the best friend. Like it hangs out, you know, it can hang out with IC, it can hang out with Vulvodynia, it can hang out by itself, it can hang out with endometriosis. So we can do all these conservative things, and sometimes they really work. And other times we have to move on to something a little bit more aggressive. And really what that involves can be something that's called trigger point injections. And it's exactly what it sounds like. It's so if you think of pelvic floor dysfunction and trigger points, like really just like a knot in the muscle, it's like taking a needle into the knot and putting a little bit of like medication to relax that knot.
So you're actually taking a needle and sticking it into a place where a patient has pain.
Right.
Are you insane?
And that's what my patients usually ask me when I first tell them, and then they have it done and they're like, thank you. Do you know what I mean? Because it's like acupuncture. You know, I mean, even when you have acupuncture for your back or anything like that, you put a needle into that area and you relax it. I know that there have been some studies on even dry needling without even using medications to relax muscles, and it's been shown to be just as effective, but I think we're just nice here, so we give a little bit of medication just so patients feel better automatically, like right away.
So you give this anesthetic, or you can put other medications in, right? Anything else?
Botox.
So Botox has been helpful also.
Botox has been actually really helpful, and we're doing a study on that right now here too. But usually what we like to do here, which I think is a nice safe way to do it, is to do some trigger points before we do Botox, since Botox is longer lasting, but we definitely offer it to patients, and we tend to have to do it a bunch.
So I happen to know that these medications that you might inject, these anesthetics, might last at the most maybe 3 to 5 hours. So how does it help you really?
So it's actually the needling of the muscle that's helping.
So and how long might it work for some patients?
Some patients, I mean, you see it work anywhere between 4 to 6 weeks for some patients. So usually we'll have patients come back anywhere between 4 to 6 weeks for another set. And if they continue to say, you know what, this is really helpful to me. And a lot of times it's really helpful in conjunction with physical therapy because you have two things working at once. So you're relaxing those muscles, and now the physical therapist is coming in and massaging those knots out. And so some patients, they don't even need Botox. You know what I mean?
Yeah, that's awesome.
Yeah.
Okay. You know what? I think in the time remaining, we have a few questions here, and then we'll sort of wrap it up for the evening. If I can read my. Okay, so this may not come out right. So besides pain, is irritation without infection common? So I guess irritation as opposed to pain. And this viewer says, I have that problem often. You want to try that one? So irritation, I guess it means that irritation, not pain. Is that really a common thing?
Yeah, one of the pain with bladder filling, even though it is one of the cardinal signs of chronic interstitial cystitis, it does not always have to be the first sign. Quite a few patients present with some irritative type symptoms, symptoms where they have maybe urgency or sensation of incomplete emptying, or even sensation of mixed symptoms. And yes, absolutely, it's very important to rule out, once again, more simple conditions like overactive bladder and see if the patient presents with some urinary incontinence. Some testing might be necessary in that case.
You know, my response to this is that, you know, what is irritation and what is pain? Because patients often come to us, they say, I don't have pain, I have discomfort, or I have, you know, pain is a really tough thing to, especially in the pelvis, to really get a hold of. When a patient tells me that they have pain right over here and it's sharp, it feels like, you know, there's a, and they can actually pinpoint it, I start worrying in that situation. This is the type of pain that patients usually discuss is very ill-defined, and they're really embarrassed that they can't verbalize what the problem really is, and that's fine. We expect that. So oftentimes it's not searing pain. It can be just discomfort or irritation. We still, if it's bothering you, and that's the most important thing to us, and that's what we gear therapy towards, and that's what pushes us forward. We can stop anywhere along the line where patients are happy. Here's another question I'm going to send to Dr. Bahlani. Pain at penetration, and then it goes away. Is that common?
Yeah, I mean, I think the big thing is that it's kind of just what you were saying, which is kind of what I was thinking in my head the whole time, is that you don't have to follow the textbook. So just because some patients with vulvodynia, if you're reading the book, it says pain with initial penetration and they continue to have pain, doesn't mean that just because you have pain with initial penetration and then it's gone away, that it's, if it's bothering you, then it's an issue, and it's something that would need to be looked into.
So here's another question. I think I'm going to send this to Marina now. It's sort of in the same lines here. Is there a reason to feel like something is there? Like a tampon isn't put in properly? Even when this viewer hasn't used tampons since her partial hysterectomy, feels like something is there. I guess sort of like the golf ball kind of analogy I mentioned before. Want to comment on that?
Absolutely. Sensation of having something in there would pretty much lead me to believe that there is some tension of the pelvic floor musculature, and why it's a very big topic. We have to deal with it as probably peeling back the onion once again. The sensation of feeling of something being there could be perhaps looked at from both perspectives, perspective of pelvic floor spasm and the bladder.
So you think that that's, and of course we would rule out other causes of discomfort that might exist. Again, it's, as you had mentioned, is peeling the onion. We want to first make sure there's no other problems going on, right. Take care of anything. If the discomfort's still there, we're still investigating. Another question I'm going to send to Dr. Bahlani. Good question. Does the physical therapy help when pain is a result of thinning skin due to menopause?
That's a great question. And that's a little bit of a loaded question. Because, okay, if you want to tell, if the cause of of pain, you're going to say it's just atrophy, it's just thinning of the vagina, I'm going to say to you that I think I have a better option than physical therapy. But the problem is that we don't know that that's the only cause of pain. And so underneath that first cause may be a second cause. So, so physical therapy might be helpful in that sense. Now, but if it's just because the vagina is thinning, sometimes you can find, you don't want to make things worse by going in there either. So that's, you know what I mean?
No, totally. It's the peeling of the onion concept. Take care of the obvious potential problem, the thinning, the thinning of the lining, which may be the source of pain. And if the discomfort's still there, we have to investigate further. And maybe it's the pelvic floor, maybe it's the bladder. These things have to be sorted out. So unfortunately, that's the end of our little time segment here, and we really appreciate you coming to view this evening. For more information, the viewers can visit the NorthShore-LIJ.com website or call the Arthur Smith Institute for Urology at 516-734-8500. Thanks so much for watching this evening.